A very good evening and a warm welcome to all the respected physicians who have joined us this evening for yet another session in the series of Neffron. Neffron is an educational initiative by Saffron Formulations that involves experts in the field of nephrology to share their clinical expertise and experience on kidney disorders. So, with this, I would like to welcome our clinical expert for today. And we are very fortunate to have with us a very young and dynamic nephrologist, Dr. Nilav Shah. Dr. Nilav Shah has done his MD and DM nephrology. He did his DM nephrology from IKDRC Civil Hospital, Ahmedabad, Gujarat, MD Internal Medicine from VS Hospital, Ahmedabad, MBBS from NHL MMMC VS Hospital, Ahmedabad again. He is a consultant nephrologist and transplant physician at Karnavati Hospital and Bodyline Hospital based at Ahmedabad. He is also a consultant nephrologist and transplant physician at BIMS Multispeciality Hospital, Bhavnagar, and he is a director at Shah Kidney Care Hospital at Bhavnagar. Based on his academic experience, he has done his clinical research on the project on DM nephrology, a single center experience acute kidney injury of obstetric origin at IKDRC. He has done his post transplant CMV infection and its impact in the national conference held in Ahmedabad in February 2017. He has also done another project on Aries case report of C1q nephropathy in horseshoe kidney in the Indian Journal of Nephrology. And with this, I would like to welcome Dr. Nilav Shah to address the audience and share his expertise on a very important topic, that is the role of alpha ketoanalogue in CKD management. So over to you.
Thank you. Slide share. So first of all, very good evening and thank you so much, Neffron. The topic is the role of alpha ketoanalogue in chronic kidney disease. In routine practice, now we are encountering so many chronic kidney disease disorders. In every age of, initially it's considered to be a diabetic and hypertension are the main etiological factor for the chronic kidney disease. But unfortunately, in recent times, many of the patients presented with a CKD of unknown origin, especially young patients, either because of low birth weight, either because of so many other structure abnormality. So, so how to retard the progression of the chronic kidney disease is the main thing and main research purpose nowadays. Because once it is a chronic kidney disease, that by definition itself suggests it is irreversible loss of kidney function. So kidney is not going to be normal, but we can retard the progression. Molecules which are actually important in retarding the progression. Among them, one is alpha ketoanalogue and another one is a pre-probiotic. So what milieu and how can they retard the progression of the chronic kidney disease? Let's see. Slide, please.
I'll share the screen with you.
Yes.
Okay.
Okay. Change the slide. As I already told, 850 million people affected worldwide, and the burden is increasing day by day. Unfortunately, the symptoms of chronic kidney disease are very vague. like fatigue, dyspnea on exertion, anorexia, nausea. So most of the time these symptoms are ignored, and most of the time we do not think about the kidney disease because some patient presented with anemia. So we used to transfuse the blood, or we used to give the iron sucrose or any other iron formulation, but we have not seen the etiological factor for the anemia. So most of the time the CKD is diagnosed very late, and the definitely lack of awareness, that is a most common factor in India because of the unawareness about the kidney symptoms particularly, and what are the risk factors for the kidney disease. Like the diabetic patient should undergo for the at least once a year kidney function testing. But we used to prescribe medicine, we used to search only for the fasting blood sugar and the postprandial. It is not only about the diabetes. The diabetes, hypertension, polycystic kidney disease, and many more. Obesity is now also considered. These are the etiological factor, and in such type of the etiological factor, the kidney function should be monitored at least once in a year until the function is normal. Next, challenges: delaying the treatment due to late diagnosis, progressive nature of the CKD leading to SRD. Yes, it's true. It is not going to reverse. That's why it is called the chronic kidney disease. And main thing, malnutrition and protein energy wasting because of uremic milieu. The main symptoms and main complaint is anorexia and nausea. The patient is not usually going to eat so many amount of the food, and just because of anorexia, the gradually the protein energy, protein intake will be hampered, and that lead to the protein energy wasting. Next. So what are the goal in treatment of chronic kidney disease? First and foremost, prevent or slow further damage to the kidney. कभी भी आप पेशेंट को बताओगे कि डायलिसिस आ सकता है, तो उसका पहला ही होगा कि सर कुछ भी कर लो, ये डायलिसिस से तो हमें दूरी रखना है. तो these are the only molecules which slow down the progression of the damage to the kidney. Maintenance of overall health, because most of the any chronic patient, any chronic disease patient, either because of the kidney, either because of liver, either because of malignancy, the main problem is the protein energy wasting. So we have to maintain the overall health, we have to maintain the immunity so secondary infection can be prevented, reduce the toxins and nitrogen load, and the balancing the intake of energy, protein, and other electrolyte, particularly when the patient having chronic kidney disease, hyperkalemia, bone mineral disorder, hyperphosphatemia, hypocalcemia. These are the secondary complications regarding the related to the chronic kidney disease. Next. So what is the alpha ketonologue? It is amino acid that are nitrogen free and that contain the essential amino acids. How does it help? It reduces the uremic toxin load. It correct amino acid deficiency and delay the dialysis. These line, the delaying the dialysis is the most important, because in any community, even if they educated, non-educated, they are just scared about the dialysis. So delay the dialysis is the main thing. Next, how it acts. So alpha ketoanalogue transaminase to essential amino acid. So alpha keto acids are converted into the essential amino acid by transamination by using the non-essential nitrogen source. So this process reduces the need of the dietary protein intake while ensuring adequate protein synthesis. What is the ideal protein requirement when the patient having a chronic kidney disease? Normal, if the patient is stable, having a no comorbidities, the 1 gram per kilogram, we already know. But when the patient having chronic kidney disease, it is a 0.8 gram per kilogram. When the patient having advanced chronic kidney disease, it is a 0.6 gram per kilogram. So if the patient having a 0.6 gram per kilogram, definitely they are going to suffer from the protein energy. So these are the molecules which helpful by increasing the dietary protein intake by reducing the nitrogenous waste product. Next. So keto acid analog, this is the mechanism already I told, and how it helpful. It reduces the formation of the neurotransmitter hormones. It improves the growth of the muscles, and by mitochondrial action, it reduces the mitochondrial toxicity. So by indirect effect, it reduces the nitrogenous waste product, ultimately urea, and that lead to the decrease in the uremic symptoms like anorexia, nausea, muscle wasting. So these are the mechanism. Next, what are the composition? Alpha ketoacids. These are the core of this medication. Each alpha ketoacids correspond to a specific essential amino acids. Alpha keto isocaproic acid is the alpha keto analog of leucine. Alpha keto acids, another one is a calcium salt, are bound to calcium salts to improve their stability and absorption. In addition to keto acids, some formulation also include the essential amino acid like lysine, threonine, tryptophan, histidine, and tyrosine. Next. Both the strand contain the same essential amino acid precursor and work through the same mechanism, but they cater to different patient profile, dosage requirement, and compliance challenges. When the double strength is required, initially it is a single strength, now it is double strength. So when the patient having a CKD stage 3 or 4 with the dietary protein restriction, elderly patient with reduced dietary intake, single strength. In advanced chronic kidney disease, when the GFR rapidly decline, malnutrition post-transplant or post-cardiac surgery, patient with a poor adherence to high tablet load. So by reducing the tablet load, it increases the compliance and adherence to the treatment. So double strength is recommended, especially in advanced chronic kidney disease. Next. Okay, what is the recommended dose? Ideally is 1 tablet per 5 kg of body weight. So 60 kg patient, 12 tablets per day. Not possible in practical sense. First, pill burden. Second, cost. So we used to give 3 to 6 tablet. Initially, the patient put on a 3 tablet. Patient should follow the exactly protein restriction about 0.6 to 0.8. And when the patient is comfortable with the medication, we increase the dose to up to 6 tablets. That's why double strength is helpful in such type of the patient because it reduces the pill burden. Overall, it reduces the cost burden also. Next. So overview of clinical benefits. Slow progression to end-stage renal disease. Reduce serum urea, creatine, and phosphate. Improve serum albumin and nutritional marker. Delay the dialysis and improve the quality of life in pre-dialysis patient. Next. So there are so many studies published in 2009, 12, and 16, including every type of the chronic kidney disease patient, stage 3 to 5. And what are the key findings? The Ketoanalogue reduced dialysis initiation 42% compared to the placebo, improved the phosphate and urea, improved the nutrition level. In a DLORIA study, GFR decline slower 1.8 compared to the 3.4 ml per minute per year. Again, improve the albumin phosphate and delay the need of dialysis. In a Chavio study, Ketoanalogue helped to maintain the serum albumin, prevent weight loss, and was very well tolerated for long-term finding. Next. KDGO 2020 updates recommended Ketoanalogue with a low protein diet to prevent the progression and maintain nutrition. Another observational randomized control trial in a diabetic nephropathy or in any other chronic kidney disease patient, irrespective of the etiology, all suggest it reduced the proteinuria, it reduced the urea creatinine level, it improved the nutrition, it improved the uremic toxins, it improved the uremia related manifestation. So ultimately, not by providing the non-nutritional supplement, it improved the nutrition and delay the dialysis progression. That is the main thing by using this molecule. Next. First of all, we should diagnose the patient at early stage so we can retard the progression. Though in a late stage, these are the molecules, but the effectiveness, personally, per my experience, because of the pill burden, because of the cost effectiveness, I think we should try in early basis in early chronic kidney disease patient so we can delay the dialysis process very for a long term. It reduces the urea creatine phosphate level. Your patient should be on a low protein diet, that is foremost, zero point 0.6 to zero point 0.8 gram per kilogram per day. Thank you. Next, single strength 1 tablet per 5 kg per day, double strength 1 tablet per 10 kg per day. Already it is administered with meals to enable transamination. Safe for use in any type of the chronic kidney disease patient, irrespective of etiology, even in elderly patient also. Any question? Thank you. Thank you so much.
Thank you so much, sir, for a very crisp presentation, and it was very comprehensive. There are few of the questions that we have received from the physicians before the session itself. So I would like you to address those. Sir,
Yes.
especially talking about alpha ketoanalogue therapy, is there any specific biological marker that you address before starting the ketoanalogue therapy?
Per se, we used to monitor the urea and creatine level. That's it. And phosphorus also.
Yes, sorry. Yes, sir. So the second question was basically like when it comes to India, especially. So there is a very varied people who come to you. The patient profile is quite different, and when it comes to protein restriction, there has been a quite a dilemma in the patient when it comes to protein restriction. People are not following it quite well. So do you think protein restriction is actually required in when it considered the Indian population?
Okay. Uh, Actually, in Indian patient, if you ask regarding the particular diet, I don't think so. Even in a normal patient, 1 gram per kilogram is usually protein intake is there, because most of the time it is around the zero point 0.6 to zero point 0.8 gram per kilogram. We used to, unless the patient is taking non-vegetarian diet. So in vegetarian diet, I won't suggest any protein restriction, particularly to the vegetarian patient. In a non-vegetarian patient, I ask them to omit meat and really fish product because they contain the higher amount of the protein. So whenever you want to get the benefit of the alpha ketonologue, the protein restriction should be there. But regarding the diet, if you ask the vegetarian patient, the one katori dal, weight gram, they are not taking eggs even. So even on a sufficient meals, the protein is already zero point 0.8 gram per kilogram. So no need of the protein restriction in vegetarian patient. You can ask the non-vegetarian patient to cut down the fish and meat product.
So you spoke about the pill burden, like since there are two strengths which are available currently in the market, and double strength being relatively a newer introduction into the market. So do you think how it is addressing the current challenge that exists in CKD patients, especially the patients who are going through dialysis?
Since last 1 year, I think initially Sun Pharma and two or three pharma company introduced the double strength. Now most of the pharma company have double strength. What is the basic problem with the alpha ketonologue? Most of the time, it is the size of the pill. Second, smell. So when you ask the patient to take the two tablet 3 times a day or 4 times a day, it is very difficult. So they change the doctor, honestly speaking, because it's cost almost 30 to 35 rupees tablet, normal around 25 to 30 rupees. So two tablet 4 times a day almost costing 200 rupees per tablet. So double strength, though the cost remains same or either 10% reduction, but it reduces the pill burden. That is the most important thing. And we can gain the benefit what exactly want to achieve. So double strength is usually preferable nowadays. I won't prefer the single strength unless the patient is very in early stage of CKD. In a CKD stage 3, we used to prescribe the single strength. Otherwise, in CKD stage 4, 5, it is a double strength only.
Excellent. So since a lot of physicians have joined us through the live stream, so usually they are the first point of contact when it comes to any of the diseases, and then there is a referral to super specialists like you. So when you give a message to the physicians who are watching us today, So, any message that you would like to give with regard to the early referral and the treatment to such patients who are going through renal insufficiency early, and where they can start the keto analog therapy early so that they don't go into the progressive stage?
In a nephrology, there are two or three options, two or three weapons, either to say option to prescribe to retard the progression of the chronic kidney disease. So I would suggest my physician friend, if the patient having any other etiological factor, unless the diabetes or hypertension, you can start the alpha ketonologue. But we have to search, is there any other possibility of any etiological factor which can be reversible or not? If it is not reversible, the treatment line would be same. Either you are prescribing alpha ketonologue or me are prescribing alpha ketonologue. But first we have to monitor the etiological factor. And when to start the chronic alpha ketonologue? In a CKD stage 4 and 5. In a CKD stage 3 patient, there are so many medication which retard the progression, like you are considered the ARBs, you are considered the SGLT2 inhibitor, you are considered the findrinon. So these are the molecules which are equally effective by retarding the progression. But once the patient in the CKD stage 4 or 5, alpha ketoanalogue should be there in your prescription.
Yes, sir, especially when it comes to diabetic patients and the elderly patients, they're already malnutrition, they're suffering from malnutrition. And it is best suggestive to start early and refer
Partic-
early to nephrologist as well.
that is the most important thing, the last line. But particularly in diabetic patient, I would like to say one line. In diabetic patient, the GFR loss is very rapid. So most of the time, when the creatine is around 3 or 4, and we are thinking about the patient having a so much delay chance of dialysis, no, it's not true. In a diabetic patient, GFR loss will be very rapid, and once the GFR losses start to decrease, then it is rampantly increasing the GFR loss. So in such a type of the patient, alpha ketonologue should be introduced early.
Yes, sir. So this brings us to the end of the session, and it was very, very comprehensive, sir. And thank you for
Thank
sharing
you.
a very practical insight, because it was more than the theory. It was more of a practical expertise that you shared with our physicians who have joined us today. So with this, I would like to propose a vote of thanks to Dr. Nilav Shah for joining us this busy evening and sharing his thoughts and clinical expertise with all the physicians who have joined us today, and for the audience for giving us the time and making our session very fruitful. Just for the knowledge that this session will be available on YouTube, and you can watch anytime and share your comments or any feedback that you have with regard to the session. Thank you so much for joining in. Thank you, sir.
Thank you. Thank you.
Thanks a lot.